Bismillahirrahmanirrahim. Today we are going to take a very interesting lecture about how to approach cardiac emergencies in neonate and young infants. I'm Dr. Hany Hadid, Professor of Pediatrics and Pediatric Cardiology. Learning outcome. At the end of this lecture, the student should be able to recognize the most common cardiovascular changes during the transition from the fetal to neonatal life, recognize the normal values of the vitals of children, recognize the different presentation of different cardiac emergencies, review the management of different presentation of cardiac emergencies in neonatal and young infants, apply the knowledge of pharmacological treatment. Pediatric cardiac emergency need to be early recognized. It's very critical, as treating them is life-saving and can reserve the cardiac functions. Late diagnosis of these emergencies can lead to significant circulatory and respiratory compromisation. The etiology of pediatric cardiac emergencies varies according to the age presentation, if it occurs in the neonatal age, young infant, child age, or according to the different clinical presentation, like if the neonate is coming with cyanosis, shock, congestive heart failure, dysrhythmia, or cyanotic spell. We have to know some basics about the cardiovascular changes occurring during the transition from the fetal to the neonatal life. As we know, the placenta of the mother is the main source of oxygen, or as we say it, it's the lung of the baby, because the placenta carries the oxygenated blood into the uh, inferior vena cava, passing through the hepatic circulation plus the ductus venosus, then up to the right side of the heart, where most of the oxygenated blood goes to the left side to be distributed across the arch of aorta and descending aorta. Little amount of the oxygenated blood moves to the right ventricles and pass to the pulmonary circulation, where most of it passes through the PDA to join the other blood into the aortic arch and aorta to be supplied to the whole body. Then the unoxygenated blood is again aggregated and passed through the umbilical arteries and passed again into the placenta of the mother to be reoxygenated again. This is what happens during the fetal circulation. At birth, the lung expands and there is a high oxygen saturation enters into the baby lung due to his crying and his first breath, leading to decreased pulmonary vascular resistance. The stopping of the placental circulation by cutting the umbilical cord increases the systemic venous return. The systemic venous resistance. There is a functional closure of the BFO. There is a functional closure of the BGA. There is a slow change from the right side dominance of the baby to the left side dominance circulation. As you see, the normal values of vitals in children, according to the age, respiratory rate starts with high values, 30 to 60 breaths per minute during the neonatal age. Then, as we proceed in age, it decreases until it reaches 12 to 20 breaths per minute as the adolescence age. Heart rate, the same, is very high at the neonatal age, then decreases till it reaches to 60 to 100 beats per minute as the adolescence age. In the reverse, systolic pressure starts by low values, 50 or 70, and increase with age until it reaches 100, 120 by the adolescence age group. This is a presentation of cardiac emergencies in neonate and young infants. First presentation occurs in the first weeks of life by cyanotic baby or the blue baby. Here the baby comes to you, as you see, after birth or just a little amount period birth in the first weeks of life with central cyanosis, no or minimal respiratory distress, and this is very important because here the cause of cyanosis is the heart and not the pulmonary condition. There is no response to oxygen or ventilation when I put oxygen on him. There is no improvement. There is a diagnostic test named hyperoxia test when you give 100% FiO2 by a mask or a hood to the baby for 5 to 10 minutes, and we measure the arterial blood gas to find the partial pressure of oxygen. If we found it below 150 millimeter mercury, this is a sure diagnosis of congenital cyanotic heart disease. What are the cardiac causes of cyanosis in the neonate? As you see, they are named the triple T's because most of them begins with the letter T. First, cardiac lesion with decreased pulmonary blood flow. And as we know, decreased pulmonary blood flow, so the dependence of the pulmonary circulation is duct dependence. Okay, there is tricuspid atresia, pulmonary atresia, critical pulmonary stenosis, and tetralogy. Another causes cardiac lesion with reversed parallel circulation as happened in the TGA, and the third cause is cardiac lesion with increased pulmonary blood flow where there is a truncus arteriosus or total anomalous pulmonary venous return. As we see, all of them when we do the hyperoxia test is 150 or below. The first two causes is below 100. The third cause with increased pulmonary blood flow, it may reach up to 150 but never exceeds it. Here are some illustrations or demonstrations for the congenital cyanotic heart disease, like the tricuspid atresia, where there is no opening of the tricuspid valve, and the whole blood goes across the ASD or a PFO to the left side, and the pulmonary circulation gets its blood flow across a VSD, then to the pulmonary arteries. If there is no a VSD or ASD, the baby dies within hours of his birth. Second one is the commonest one, which is the tetralogy of Fallot, and this is the components, large perimembranous VSD, right ventricular outflow tract obstruction, or as we say, subfundibular pulmonary stenosis, right ventricular hypertrophy, and overriding of aorta, taking the blood, the mixed blood here from both ventricles. TGA is very common also. There is aorta arising from the right ventricle and pulmonary arising from the left ventricle. Truncus arteriosus, where there is a main trunk coming from both ventricles, and this trunk later divides into pulmonary artery and aortic arch, and here there is a mixing of the oxygenated and non-oxygenated blood. So this was some examples of the cyanotic baby with increased pulmonary blood flow and decreased pulmonary blood flow. Let's come again to the most diagnostic test, which is hydroxia test, where we give 100% oxygen to the baby through the oxygen hood or a face mask. Then we measure the partial oxygen pressure. If we found it in the ABG, of course, when we found it below 100 or from 100 to 150, this is a sure diagnosis of congenital cyanotic heart disease. If it is above 150 but still below 300, it may be caused by a pulmonary disorder like pneumonia or CNS disorders like CNS depression by anesthesia or a disease called methemoglobinemia. If we find it above 300 millimeter mercury, this is the normal, and this excludes congenital cyanotic heart disease. A further evaluation of the cyanotic baby is by chest X-ray. Look at this X-ray. As we see here, there is a increased pulmonary blood flow with increased pulmonary congestion. This is a cyanotic baby with decreased pulmonary blood flow. If there is a characteristic appearance in the X-ray like boot-shaped heart in the tetralogy of Fallot or H-shaped or snowman shape in the total anomalous pulmonary venous return or acorn string like on the TGA transposition of great arms. Please take a note that if you find a differential diagnosis in the right upper limb or the upper limb is pink than the lower limb, which is blue, or there is a difference in the saturation between the upper limb and lower limb, there may be resistant pulmonary hypertension of the newborn or interrupted aortic arch, palpitation of aorta, and the flow of blood comes from the PDA, where there is a high pressure to the supplying the lower limb, causing a cyanosis in the lower limb and a pink upper limb. How do you manage cyanosis baby? If you suspect a duct-dependent pulmonary circulation, like from the X-ray, there is oligopic lung field, partial oxygen pressure is below 100 millimeter mercury, or suspect a cardiac lesion with parallel circulation, pulmonary, pressure, oxygen pressure is less than 150. So, with the echo, of course, you have to start the prostaglandin E1 infusion with this dose, but take care. Prostaglandin infusion may have side effects, which are apnea, hypotension, fever, distress, seizures. So you have to weigh the advantage you take from the prostaglandin infusion against the side effects. You have to correct the acid-base balance. You have to do pulmonary septostomy in cases of TGA, where here we do an artificial ASD with a balloon septectomy to allow mixing of blood between the two parallel circulation and the transposition of great arteries, then surgical consultation can be done. Second presentation for our patient is shock or the gray baby. Also, it happens in the first weeks of life where you found a baby suddenly sick, collapsed, color is not looking good, black, pale, or gray baby as you see in this picture. There is a poor feeding, not passing urine, cold preference, poor pulsation, low cardiac output, tachypnea, tachycardia, metabolic acidosis, and raised lactate. The cardiac causes of shock may be left-sided obstructive lesion. There is a low cardiac output passing to the left side, as happened in hypoplastic left heart syndrome, critical aortic stenosis, critical coarctation, or interrupted aortic arch. And here, the systemic circulation depends on the BDA. So it's named back-dependent systemic circulation. Another cardiac cause is the myocardial disease, like myocarditis, cardiomyopathy, asphyxia. Another cause from the cardiac causes of shock dysrhythmia, either tachyarrhythmia or bradyarrhythmia. You have to differential diagnosis this patient when you see him from the septic or the hypovolemic shock. There is a picture of our illustration of hypoplastic left heart syndrome where you see that the left ventricle is very small and the arch of the aorta, ascending aorta and arch is hypoplastic. It is supplied by the BDA to give blood supply to the lower limbs across the ascending aorta. Coarctation of aorta, where there is a narrow area here, and the interrupted aortic arch, where the arch stops after the third branch, and the BDA continue to the lower limb to give it its blood supply. Evaluation of a baby with shock is to do arterial blood gases. You will find metabolic acidosis, do chest X-ray, and you will find cardiomegaly and lung congestion, do ECG and echo. Management, as any drug-dependent systemic circulation or pulmonary circulation, you have to use the prostaglandin infusion, as we said, to take care of its side effects, to maintain the flow and perfusion of the systemic circulation, correct the acid-base balance. You can do mechanical ventilation to decrease the oxygen consumption. You have to support the heart with inotropes and after load reduction, control the heart rate, and arrange for BDA stenting or surgical correction. If you give prostaglandin infusion and there is no improvement, so you have to exclude, as we said, the non-cardiac causes of shock, which is septic or hypovolemic shock. Third presentation is the congestive heart failure or the pink baby, as you said. As you see, the baby becomes congested and pink, and this happens in a baby at the age of 6 to 8 weeks. Why at this age? Baby comes with congestive heart failure. At this age, normally the pulmonary vascular resistance drop to the normal. Okay, so if there is a large shunt, left to right shunt, it will not be functioning with a high pulmonary vascular resistance, but it will be functioning after dropping of the pulmonary vascular resistance, and a left to right shunt will become very massive. Again, the characters of the pink baby is interrupted, prolonged feeding, sweating with fits, tachypnea, tachycardia, subcostal indrawing. There is increased risk of respiratory infections. There is a gallopresence, hepatomegaly, and edema. Of course, after the age of 6 to 8 weeks of life. What are the cardiac causes of congestive heart failure? Maybe cyanotic causes or cyanotic causes. Cyanotic causes, as we explained, the significant left to right shunt, VSD, BDA, AVSD, or aorticopulmonary window. Maybe severe valvular regurgitation, cardiomyopathy, dysrhythmia, infectious diseases causing pancreatitis, or acquired disease like Kawasaki disease or normal left coronary from the pulmonary artery. There is also cyanotic heart diseases causing congestive heart failure like TGA with VSD or cardiac mixing lesion with increased pulmonary blood flow like truncus arteriosus and total anomalous pulmonary venous return. Is there a non-cardiac causes for congestive heart failure? Yes, anemia, cytotoxicosis, and sepsis. As you see, this is a VSD between the left ventricle and right ventricle, and due to the high left ventricular side, the blood passes from the left ventricle to the right ventricle. In the atrioventricular canal defect, which happens mostly in Down syndrome, there is defect absent endocardial cushion, resulting in a large perimembranous VSD, a large primum ASD, and absent endocardial cushion and septal leaflets. So there is only one leaflet, one common leaflet covering the atrioventricular canal with severe regurg. Evaluation of any baby with congestive heart failure, arterial blood gas, chest X-ray, you will see cardiomegaly, lung congestion, hyperoxia test, and ECG and echo. Management of heart failure, you have to give the baby high caloric intake, preload reductions, diuretics, and fluid restriction. After load reduction, ACE inhibitor, inotrope by its different types like dopamine to vitamin and digoxin. We have to control the heart rate for dysrhythmia and do cardiac corrective surgery. This is an algorithm for a baby coming with congestive heart failure. If he is acutely decompensated and you don't know the cause, please exclude extra cardiac causes like anemia, cytotoxicosis, sepsis, and manage according to the cause. Or if you know that he has cardiac heart disease, either cyanotic or acyanotic or arrhythmia or what else, you have to give diuretics, inotrope, and vasodilator for the heart failure, and then you have to manage the etiology according. Is it a congenital heart or it is acquired heart disease? Fourth presentation is arrhythmia. Arrhythmia may be tachyarrhythmia with heart rate more than 220 beats per minute or bradyarrhythmia heart rate less than 60 beats per minute with signs and symptoms of congestive heart failure. What are the types of arrhythmias affecting babies? And this occurs at any age of presentation, neonate, infant, or childhood presentation. Tachyarrhythmias like supraventricular tachycardia in the first strip, as you see, atrial flutter, you see here the flutter waves, ventricular tachycardia, wide complex tachycardia, or junctional ectopic tachycardia, and this occur post cardiac surgeries. Bradyarrhythmia, like the last strip here, there is complete heart block, the most dangerous one, and its risk increase in cases of neonates born to systemic lupus mothers or post-surgically corrected TGA. We can evaluate by ECG and echo management according is the supraventricular tachycardia. Pre-hospitalization at home, we can teach the mothers to simulate vagal maneuvers for her baby, like putting ice bags on his face or asking him to strain for activating the vagal maneuvers. Hospital, when the baby arrives with supraventricular tachycardia, can give him adenosine with 100 to 200 mic dose, and we can repeat it every 2 minutes. Synchronized cardioversion can stop the attack. Digoxin, beta blocker, flecainide, amiodarone also from the pharmacological management to the supraventricular tachycardia. Ventricular tachycardia is managed at hospital by cardioversion by a higher dose, 2 to 4 joules per kg. We can address the treatable causes and treat it, say, like electrolyte disturbance and acidosis. Pharmacological therapy, we give different antiarrhythmic drugs like lidocaine or amiodarone, and we can put an implantable defibrillator which can give the heart shock when ventricular tachycardia occurs because it's lethal to have a ventricular tachycardia. Bradyarrhythmia, we have to treat the cause. If there is electrolyte disturbance, we can give atropine and adrenaline for increasing the profound sinus bradycardia, increasing the heart rate, and we can consider temporary or permanent pacemaker or making an epicardial pacemaker. The last presentation in our cardiac emergencies in the children is hypercyanotic spells. It occurs mainly at the age of infancy in the first year of life. Like you see, it is characterized by sudden decrease in pulmonary blood flow, usually in the morning, provoked by crying, feeling, hypovolemia, infections, by auscultation. If we already hear a murmur, the murmur becomes faint or disappears, systolic murmur. This happens in the case of tetralogy of valve or pulmonary atresia, and this is a bad sign if you didn't hear the murmur after being heard, because this means that there is no blood coming through the pulmonary. Evaluation by arterial blood gas, chest X-ray, and echo. Management, as you see, first you have to calm the baby, position him like the niches position or squatting position if he can do it, give him oxygen, morphia for calming the baby, beta blockers to dilate the infundibulum, phenylephrine to increase the systemic vascular resistance in the aorta, and force blood to go into the pulmonary. And if he is indicating with recurrent cyanotic spells, you can send him to surgery to do either palliative BT shunt or a total repair. Summary: the main presentation of cardiac emergencies in neonate and young infants are maybe cyanosis in cases of drug-dependent pulmonary circulation, and we enumerate him as a blue baby. So, in drug-dependent systemic circulation, and he is a gray baby. Congestive heart failure, like in shunt lesion, he is the pink baby, may present with dysrhythmias or hypercyanotic spells. In the first 2 weeks of life, normally, the duct takes from 2 to 14 days for permanent closure, so be aware of duct-dependent lesion, either pulmonary or systemic. If you suspect a duct-dependent lesion, either carrying blood to the pulmonary or carrying blood to the systemic circulation, don't be afraid and start the prostaglandin E1 infusion with a balanced dose to avoid its side effects. At the age of 6 to 8 weeks, normally, if there is a large shunt lesion making left to right shunt like the VSD, AVSD, or BDA, they don't appear until the age of 6 to 8 weeks because at birth right side pressure is high, so the shunt is minimal and there is no symptoms. After the 6 to 8 weeks, the right side pressure drops, normally drops in all populations, and left side pressure increases, so the shunt symptoms appear. In infancy, the tragedy of Fallot can present by spells, and here we can add the arrhythmias that happens in any age. An important message from our lecture is that vital signs and the clinical examination and presentation are very important. Before you make an echo for a patient that you are suspecting to have a drug-dependent lesion, drug-dependent pulmonary circulation, drug-dependent systemic circulation, or any cardiac lesion with parallel circulation like the TGA, or any baby coming with persistent metabolic acidosis or severe cyanosis, give the prostaglandin E1 even before you do the echo till you do the echo to maintain the BDA open. This is our lecture. Questions for discussion. Question 1. If a baby girl coming to you, you noticed her to be cyanosed on her first day of age. No murmur is here and there is no respiratory distress, and this is very important. There is no respiratory distress. On the second day, cyanosis is more obvious. Which of the following is correct concerning this patient? Is cyanosis is most likely due to chest condition? Is the baby's color should improve rapidly after giving 100% oxygen? Echocardiography can often tell the anatomical state of the newborn circulation. The baby chest X-ray shows a small heart. This is again is the diagnosis of congenital heart disease. The lack of murmur is against the diagnosis of congenital heart disease. The answer is C. Here, cyanosis is not due to chest condition because there is no respiratory distress symptoms. The baby color, if he has congenital cyanotic heart disease, it will not improve after giving 100% oxygen. The baby chest X-ray, if show a small heart, this is not against diagnosis of congenital heart disease, as the tetralogy of Fallot baby have a small heart. The lack of murmur is again the diagnosis of congenital heart disease. This is wrong because in cyanotic spell, the murmur disappears. Second question, if a 1-year-old infant is known to have heart disease and is noted to be cyanosed, which of the following is most likely diagnosed? Is it an atrial septal defect? I don't think so. Is the coarctation of aorta, latent ductus arteriosus, truncus atresia, tricuspid atresia, or ventricular septal defect? I think it's very easy that tricuspid atresia is the one with the cyanotic heart disease. These references for further readings. You can read more about the topic. Thank you.